Okay. All right, I'm going to get started while people are eating and getting food and finding seats, because I know that you're all in a hurry to leave. You have a meeting at 1:15 or something, or you're having a party at 1:15, whatever. Anyway, I am as different from this party. I'm going to talk to you today a little bit about inflammatory bowel disease. It was hard for me to figure out what tack to take on this because there are so many possibilities, and I was trying to tailor it a little bit to an audience that I was told was GI and inflammatory and infectious disease and pulmonary, and I wasn't sure how to make all those three unite. But I think what I would like to do is give you a more broad overview of inflammatory bowel disease, what it is, and then touch very, very briefly on some of the treatments that we use and how we at the DCRI look at designing clinical trials to evaluate treatments for inflammatory bowel disease. So without further ado, this slide is courtesy of my friend Anne. One of the most common mistakes in inflammatory bowel disease when transcribing it is either to call it irritable bowel or to call it inflammatory bowl disease. And so someone has designed this inflatable, infamous, inflamed bowl, which is obviously for inflamed stool contents. So what I would like to talk to you initially about a little bit of background in terms of the epidemiology of inflammatory bowel disease. And typically we include two disorders in the sort of broader umbrella of inflammatory bowel disease. One is Crohn's disease, and the other is ulcerative colitis. And for decades, we thought that these two diseases were distinct entities. But as time has gone on and we have become a little more sophisticated in our ability to look for some serologic markers and to drill a little deeper in terms of genetics, we realized that these probably are at ends of a continuum, and that there are many people in a group in the middle who have Crohn's that behaves like ulcerative colitis, or ulcerative colitis that behaves like Crohn's, and they're probably not as distinct entities as we once thought. But in terms of how we think about the etiology of inflammatory bowel disease, sort of have a three-pronged theory here, which typically means we don't really know what the real etiology is. But we know that there is sort of a genetic predisposition, and that inflammatory bowel disease tends to cluster in families. But we also know that there are some immunologic abnormalities that are unique to patients with inflammatory bowel disease and that can be described. And then we know there are some environmental factors, a few of which we know, but many we don't know. And the search is always on to try to identify more of the environmental factors or things that might trigger inflammatory bowel disease. So in theory, what we believe is that patients are genetically predisposed to develop inflammatory bowel disease, but that a series of events has to occur, and typically that would be something triggering the expression of the genetic predisposition. So as you can see here, if you look at twin studies, and monozygotic or identical twins, even identical twins don't always develop the same disease. So identical twins, about 58% of the time, will both have Crohn's disease, but that means that 42% of the time they don't. So there's something more to the story than genetics, although there is clearly a genetic predisposition. And when you look at here, not nearly the same as far as dizygotic or fraternal twins, but you can see as far as ulcerative colitis and Crohn's are concerned, there's a much stronger genetic association with Crohn's disease than there is with ulcerative colitis. And typically we find a family history in about 10 to 20% of patients who present with inflammatory bowel disease. And of those, about 5 to 10% will have a first-degree relative with inflammatory bowel disease. But almost always, but not always, it's the same diagnosis. So if someone presents with Crohn's disease and has a first-degree family member with inflammatory bowel disease, the most likely is that the family member also has Crohn's disease, and the same would be true for ulcerative colitis patients presenting with family members who have ulcerative colitis. Some of the environmental triggers I mentioned, infections, we know that frequently, patients who present with a new diagnosis of inflammatory bowel disease will give a history of having traveled to Mexico and developed traveler's diarrhea. They may be with others who also develop the illness, so it's pretty clear that it was an infectious trigger. But whereas the other members of the group cleared the infection quickly, the patients who ultimately are diagnosed with inflammatory bowel disease sort of never got over the initial event. So they developed what seemed like an infectious trigger, but then it unmasked the underlying genetic predisposition to inflammatory bowel disease. We're not sure if there are antibiotics, but frequently antibiotics cause diarrhea, and sometimes that diarrhea just persists. Non-steroidals are another commonly associated trigger for inflammatory bowel disease in mice that are genetically predisposed, but also we believe in patients who are genetically disposed. Smoking, this is one of the interesting observations that has occurred over the last 20 years. Smoking seems to be protective for ulcerative colitis. So patients who smoke are not likely to develop ulcerative colitis, but when they stop smoking, they frequently develop colitis symptoms. And if they have known colitis and smoke, when they quit smoking, their colitis tends to flare. The reverse is true for Crohn's disease. So patients with Crohn's, if they smoke, their disease tends to be much more aggressive, much more difficult to control, and much less responsive to treatment. I talked briefly about on the three-pronged approach, if you will, to the etiology of IBD. We talked briefly about the immunologic abnormalities. And just to put it in sort of a context, the normal gut would have sort of this normal non-inflamed state. And then something would come along, an environmental trigger of some kind. It could be a bacterial product. It induces this inflammation that in a normal host, the individual would be able to downregulate. So there would sort of be this restoration to normal after a short time. So this would be a self-limited inflammatory state. But in patients who are genetically predisposed, something prevents the body from downregulating. So it prevents it from restoring it to the normal state, and you get this chronic, uncontrolled inflammatory bowel disease in which the inflammation never disappears unless you treat it. Just a slide to show you that the most common or the most frequent age at presentation is typically the late teens to the early 20s for both ulcerative colitis and Crohn's, but there is sort of a little bit later peak, a lower peak slightly later in life in the sort of 50s and 60s for both diseases. So how do we make the diagnosis of inflammatory bowel disease? Typically we take a history, but as you will see, the history is not always that reliable. Physical examination we would do on everyone, but again, it doesn't usually tell us this is inflammatory bowel disease versus any other diarrheal illness. Laboratory tests are sometimes helpful. Almost always we make the diagnosis by some form of endoscopy or radiography, an X-ray, a barium study, or a CT scan, and then typically the final diagnosis is made by histology or biopsying tissue samples and looking at them under the microscope. So I wanted to touch briefly then on the two, even though I said that these are more two anchors on a spectrum or on a continuum, we do still think about them and group them as ulcerative colitis and Crohn's disease. And so I wanted to talk to you first about ulcerative colitis a little bit in terms of the clinical presentation, and then Crohn's disease, and show you some areas that the two have in common, and then sort of where they differ, and then talk to you a little bit about the treatments. So by definition, ulcerative colitis is confined to the colon, which means that if there's any other area of the gastrointestinal tract involved, you have to think this is not ulcerative colitis. Slightly higher prevalence in males, but almost one-to-one as far as clinical diagnosis is concerned, and roughly equal prevalence as far as Crohn's is concerned, at least in this country. Some of the clinical features, almost always the patients present with diarrhea that is typically bloody. And I have found in practice that blood is one of the symptoms that brings people to the doctor. Diarrhea doesn't always. So when the patients as soon as they see blood, they typically tend to seek medical attention. So for that reason, I think the time to make the diagnosis of ulcerative colitis tends to be shorter than Crohn's disease. As you'll see in a minute, the symptoms of Crohn's are not quite as uniform. Almost always, the patients with ulcerative colitis will have bloody diarrhea, a sense of urgency, like they have to get to the bathroom quickly, or what we call tenesmus, which is where they feel like they have to go to the bathroom, but when they go, there's nothing there. The distribution of ulcerative colitis, we typically describe this as either limited disease, which means sort of just the rectum and the rectum plus the sigmoid colon. Then we have what we call left-sided disease, which this is the left side of the colon. And the nice thing about ulcerative colitis, in a way, is that you will see a sharp line of demarcation. So if you put the scope in, you would see it would be inflamed up until all of a sudden there would be a sharp line, and on the other side of that line it would look completely normal. And if you biopsied it, it would usually be completely normal. That's in contrast to Crohn's disease, and I'll show you some slides of that in a moment. But so we by definition, the rectum is involved in ulcerative colitis, and the question then is how much more of the colon is involved. This becomes important in terms of treatments because not all of the treatments are distributed equally throughout or evenly throughout the colon, and also in terms of prognosis because the risk of developing colon cancer is in part related to how long you've had ulcerative colitis, but also to how much of the colon is involved. So if the entire colon is involved, then the risk is that much higher. So for reference, this is what a normal colon would look like with on endoscopy. And you can see their nice blood vessel pattern here. This is a little blood vessel, and you can see they sort of have these little small delicate branches off the bigger blood vessel. And then this is the light from the scope reflecting off the mucosa or the innermost lining of the colon. And you can see it sort of glistens. It has a very shiny appearance. This is what we would call mildly active colitis, ulcerative colitis. And you can see that it's very what we would call granular. It's all dotty. It doesn't have the nice sheen and that sort of glistening appearance that the normal colon had. And you can also see you can't make out any of the blood vessels distinctly. This is more moderately active ulcerative colitis, and you can see these are sort of deeper ulcers here that are forming. But again, it's confluent. The inflammation is involving the entire circumference of the colon wall. This is severe, and this is all ulcerated area. It should all look like that first slide of the normal mucosa. Well, in contrast to ulcerative colitis that only involves the colon, Crohn's disease can involve any part of the GI tract, so mouth, esophagus, stomach, small intestine, or colon. It's most commonly found in the terminal ileum, or the last portion of the ileum before it enters the colon, or in the colon, or both. Slightly higher prevalence in women than in men, and as before, roughly equal in terms of prevalence with ulcerative colitis. Some racial differences: whites tend to be more affected than blacks, and than Asians. And in terms of ethnic differences, Jewish much more so than non-Jewish, and within the Jewish population, Ashkenazi Jews much more so than Sephardic Jews. So this is lending validity to the genetic predisposition, and is the basis in many ways of some of the genetic studies that are being conducted now. In terms of the risk of developing Crohn's disease, I like this slide because it sort of tells an individual patient what their risk could be, or tells a potential parent what the risk of an offspring developing Crohn's disease would be. So the offspring, if two parents are affected by Crohn's disease, would be about 50%. If you have a monozygotic twin with Crohn's disease, the risk is about 37%. If you're related, or if you're a sibling, a first-degree relative of an Ashkenazi Jew, it's about 16.8%. And this is in contrast to a sibling of a non-Jewish individual, would be about 4%. if you were the general population, about 0.1%. So there are what we call sporadic cases, but you can see sort of the influence of the genetic markers, or excuse me, the influence of genetics on the development or the likelihood of developing Crohn's disease. Not as well described for ulcerative colitis. And part of that gets back to the idea that even in monozygotic twins, ulcerative colitis does not appear to be as much affected by genetic predisposition as Crohn's does. I mentioned earlier that the vast majority of patients with ulcerative colitis present with bloody diarrhea. And in contrast, the patients with Crohn's present with almost any symptom. Frequently, they have abdominal pain. It may occur after a meal, but not always. They often have diarrhea, but not always. Rectal bleeding tends to be extremely uncommon compared to the bleeding that happens in ulcerative colitis, and almost every patient with ulcerative colitis will exhibit rectal bleeding. They may present only as weight loss or fever or overwhelming fatigue. Some patients have pain on the right side because it tends to affect the terminal ileum and the colon at the start on the right side. But in children, it may only be that they fall off the growth curve. So it's much more difficult, I think, for pediatric gastroenterologists and pediatricians to make this diagnosis. So you have to be pretty sharp and look for reasons that a child may be falling off the growth curve, and this Crohn's disease is one of them. Sometimes we get a clue like a perirectal abscess or a fistula, which is much more common in Crohn's disease and almost never occurs in ulcerative colitis, but those can occur in people who don't have inflammatory bowel disease as well. As I mentioned, Crohn's can involve the entire GI tract, but only about 5% of patients have involvement above the small intestine. So 5% have esophageal, stomach, and small intestinal involvement. About a third have disease that's only in the small intestine. About a quarter have disease that's only in the colon. And this group tends to be harder to distinguish from ulcerative colitis because their disease is only in the colon. And about 40% have disease that involves both the colon and the small intestine. Some of the types of of Crohn's disease that we tend to classify patients as having inflammatory. They typically have pain and tenderness as well as diarrhea. Some of the patients develop stricturing disease. So you can see here there's this narrowed segment here and a narrowed segment here, and in between the intestine sort of balloons out. That's scar tissue, and that scarring tends to cause blockages. And so those patients are the ones who are more likely to have pain after a meal or nausea and vomiting after eating. Fistulizing Crohn's is a unique characteristic of Crohn's in which the bowel sort of burrows its way, the Crohn sort of burrows its way to anything in the neighborhood. If it's skin, it will create a fistula tract to the skin. If it's another loop of bowel, it will create sort of this communication between two loops of intestine. But if it's the bladder that's nearby, it can create a fistula or a sort of a bridge between the bowel and the bladder. So there are a number of fistulous complications that can occur with Crohn's and are a definite tip-off that we're dealing with Crohn's disease rather than ulcerative colitis. The differential diagnosis of Crohn's is quite large. Some of the patients can be initially thought to have lymphoma, or lymphoma certainly in the differential diagnosis when evaluating a patient who has sort of a mass-like inflammatory condition on the right side of the abdomen. There's some infectious things that can mimic Crohn's disease. Appendicitis frequently, because this affects sort of teenagers, young adults or teenagers. The patients are taken to the operating room for what is presumed to be appendicitis, and the surgeon opens up and says, oh, it's not appendicitis, it's Crohn's disease. That happens less now than it did maybe 20 or 30 years ago because of the use of CT scans. So now all the patients who come to the emergency room get a CT scan, whether you have a toothache or whatever. But so it's a little bit less common that we misdiagnose appendicitis and end up in the operating room saying this person had Crohn's, but it still does happen. Oh, this was just to remind you of what the normal colon lining looks like. And this is a slide showing the earliest features of Crohn's involving the colon. And you can see this is not that different in appearance from the early mild ulcerative colitis. But as the disease starts to increase in severity, you can see these are huge, deep ulcerations that we call serpiginous. They sort of snake along the bowel. And the bowel in between them is much closer to normal than it was in the patients in the slides of the ulcerative colitis. This is a feature we call cobblestoning, where an ulcer has actually sort of excavated an area of normal colon in between two ulcers, and this is what we call the cobblestoning effect, typically based on what was seen on a barium study, but also what we see endoscopically. And interestingly, if you were to biopsy this, it would come back as an ulcer. Sometimes this would come back as normal colon. So this is what we call a skip area in Crohn's disease, where it's not continuous or contiguous with other areas of inflammation. There are areas of severe inflammation directly adjacent to areas that are normal. These are little pseudopolyps. A lot of people know that polyps are associated with colon cancer. These look like polyps, but they're not, so they're called pseudopolyps. And actually, I think they look like more like stalactites or mites or whichever one, but they are actually just areas where the ulcerative colitis has sort of scarred and left this long sort of villiform tissue kind of hanging out in the center of the colon. Some of the complications that I mentioned, the fistulas, which are the communications between the bowel and anything next to it. Fistulas are really leakages and from the bowel wall. So if the fistula reaches to another organ or to the skin, then you're less likely to have an abscess. But if the fistula just sort of ends, if the wall of the intestine sort of perforates and the bacteria spill out into the surrounding area, the patients frequently develop an abscess. We mentioned the stricturing complications that can lead to blockage. Some of the extraintestinal manifestations, I'll show you some slides of these in a moment, but the patients tend to have arthritis that is inflammatory, and treatment of the underlying Crohn's resolves the arthritic symptoms. Again, this is a slide just showing the tunnel formation. This is a fistula between two areas, two loops of small intestine here. This is fistula. This is the opening, so the intestinal contents are sort of coming out the wall, the abdominal wall. This is quite small. There are some patients who have enormous fistulae, enormous openings that they have to wear an ostomy bag just because it's draining constantly. This one is around the anus. So this is the anus, and this is a fistula that just sort of leaks pus, sometimes a little bit of stool, sometimes blood, but these can be exquisitely painful, and some of the patients can get an abscess underneath, and then they can't sit down. You can imagine. It doesn't take a stretch. We talked about the stenosis or the stricturing segments, and this is a small bowel follow-through where the patient drank barium and then they watched it as it went down. This is the colon, and you can see this is sort of the normal diameter of the small intestine, and you can see how narrowed. It's just this thin, tiny wisp of contrast is getting through right here. You can imagine if the barium can't get through, how hard it is for meat and vegetables to get through. Again, this is sort of the more normal diameter of the small intestine, and here you can see how thin it is with the stricturing segment. So we've talked a little bit about how the two diseases present, and this slide simply summarizes sort of how we as clinicians try to distinguish between ulcerative colitis and Crohn's and the factors we take into account when we see a patient in clinic. So the ulcerative colitis, by definition, can only involve the colon and the rectum, but Crohn's can involve any part of the GI tract. The distribution for ulcerative colitis is quite diffuse, but in Crohn's it has these skip areas where it's abnormal and then normal and then abnormal again. Fistulae and abscesses almost never occur in ulcerative colitis, but are quite common in Crohn's. The stricturing, also common in Crohn's, but doesn't tend to occur in ulcerative colitis. The rectum is almost always, by definition, involved in ulcerative colitis, but doesn't have to be involved in Crohn's disease. Bloody diarrhea as a presenting symptom is very common in colitis, but not in Crohn's. And then the smokers, it's rare that a current smoker will present with ulcerative colitis. And, well, I shouldn't say rare. It's less common that a smoker will have ulcerative colitis, and much more common that a smoker will have Crohn's disease. Some of the extraintestinal manifestations of both ulcerative colitis and Crohn's, and I'll just breeze through. These are mostly just slides showing what some of these things look like. But the point here is that ulcerative colitis and Crohn's can affect not only the intestinal tract, but almost any other organ system in the body. And here, this is a slide showing what is called Erythema Nodosum. These are very tender, they look like bruises here, but if you were to feel one, it's like a nodule under the skin. It's like a little golf ball under the skin, exquisitely tender. They typically occur on the shins, but this person has it on the calf. This is very advanced Pyoderma Gangrenosum. It usually starts as a tiny little, it looks almost like a tiny pustule or pimple, and if it's not treated, can obviously advance. And this is clearly an extraordinarily advanced case. But these tend to scar over eventually. This is the inflammatory. These are called sausage digit toes, and they do kind of look like sausages. This is an inflammatory arthritis associated with inflammatory bowel disease. More arthritis. You can see the swelling of the joints. Unlike some of the arthritides, like rheumatoid arthritis, where you see the ulnar drift, you don't usually see that pattern with the inflammatory arthritis that occurs with IBD. Sacroiliitis is, and I'm not sure you can appreciate it here. This is the sacroiliac joint, or the union of the sacrum with the iliac crest. And a lot of these patients present with back pain, and when you take an x-ray, you can see that there is what we call sacroiliitis, or inflammation of this joint in the back. It's a condition called Ankylosing Spondylitis, or bamboo spine, and these people have, he's slightly hunched over, but mostly his spine is exquisitely straight, and they have very restricted mobility of the neck, and they can't bend over. This is a condition called uveitis, which is dramatic, to say the least, and scleritis. This is quite painful, and typically these patients will know that something's wrong and seek medical attention quickly. This is a condition of the bile ducts called Sclerosing Cholangitis, and is precancerous, and is one of the most common reasons that patients get a liver transplant. So you can see it's all supposed to be very smooth and slightly and delicate, but you can see there's sort of these, similar to the barium study I showed you earlier, where we have narrowed areas and then ballooned areas, and then narrowed areas and ballooned areas. So this pattern is something we find on endoscopy, on a special kind of endoscopy called ERCP. The oral ulcers, these are little tiny canker sores almost that are very, very painful, that typically follow the inflammation. So when a patient has a flare of the Crohn's, they may develop these ulcers in the mouth, and these typically go away when the disease is treated. One thing I think that is often overlooked is the impact that these diseases, because they're chronic, have on patients' sense of well-being. And there have been a number of studies lately, but this one sort of shows you the association or the coexisting anxiety and depression in patients who have Crohn's disease and ulcerative colitis. You can see a very high association of anxiety in both Crohn's and ulcerative colitis, a little less so depression. But I think it's important to remember that that to look for these when seeing a patient in clinic. One of the things that has frustrated many investigators in terms of clinical trials is what is our definition of what is the goal of therapy. So in clinic, we say, well, we want to induce remission, and by that we mean that the patients won't have any symptoms. But in clinical trials, we're looking for something slightly less than, we will take something that's not quite remission, which means that there are no symptoms and no evidence of active disease. We will accept what we call a response, meaning the patients had significant improvement in their symptoms, even though they didn't actually meet what we would say a threshold for being in complete remission or having no symptoms. Once we can induce remission, our goal is to then try and maintain that remission. So some of our treatments are geared toward putting the patients in remission, but once they're in remission, we have to have treatments that can sustain that remission. One of the treatments that is used to induce remission is steroids, and because of the side effects of steroids, we're trying to minimize the use of steroids and get the patients off of steroids. So we look for drugs in clinical trials that can not only induce remission, but enable patients who are on steroids to come off the steroids and stay off the steroids for long periods of time. We're looking to restore and maintain adequate nutrition. We're looking to restore and maintain quality of life, and not the least of which involves the anxiety and depression that can go along with these illnesses. And then for patients who need surgery, we're trying to figure out when is the best time for them to have surgery. So as I said, in clinical trials, when we have outcomes for clinical trials, we have to come up with definitions for what would be response and what would be remission. And so we have developed clinical disease activity indices. One is the Crohn's Disease Activity Index. Another is the Harvey-Bradshaw Index. There's a Mayo Score. There are a number of indices that are out there that are ways that we can compare in clinical trials response or remission from patient to patient, but also from trial to trial. Unfortunately, not every trial uses the same series of indices, but for most of the trials involving Crohn's disease, at least to date, we've used the Crohn's Disease Activity Index. Unfortunately, as I'll show you in the next slide, the Crohn's Disease Activity Index is developed by taking, a patient has to keep a diary for 7 days, and actually for clinical trials, they keep it for the entire duration of the trial. And then we take the number, they record on the diary the number of bowel movements they have each day, a sense of well-being. They record whether they have abdominal pain, whether they've taken anything for diarrhea. There are a number of questions that patients have to answer every day, and then they bring their diary in to the study coordinator, who takes the 7 days in sequence, adds up all the figures, all the numbers, multiplies those by a factor, comes up with another number, and then adds all those numbers to come up with a final score. And you can imagine it's incredibly cumbersome. It's also very subjective. A patient may not feel well because of a number of things, not just because their Crohn's is active. The other thing is that the populations we're studying are not uniform. So if we include Crohn's patients, but that means some have small bowel disease, some have colon disease, some have small bowel and colon disease, some have fistulae, some don't. We're sort of grouping together as Crohn's disease a number of patients who have very different manifestations of their Crohn's. And that makes comparing, it's really very much like comparing apples and oranges. We have quality of life instruments that we use. Sometimes now we're using endoscopic indices to try and prove that there is not only that the patient feels better, but that there is also evidence on endoscopy that the lining of the colon is happier. The problem with that is that those are also quite cumbersome, and if every trial had to pay for every patient to have a colonoscopy at baseline and at the end of treatment, the cost would be prohibitive. We also take biopsies and use biopsies in some of the clinical trials, and there is now a new term called hard remission, which means that you don't have any symptoms, your endoscopy looks good, but also on histology you have no active disease. So the criteria for what we're calling remission we're trying to make them a little bit more stringent than we have in the past. These are the questions sort of that have to be answered by the patient in the diary. The number of liquid or very soft stools every day for the previous week. They rate their severity of abdominal pain, their sense of well-being, whether they have any extra intestinal manifestations. Then when they come in for the visit, we determine whether or not they have an abdominal mass on exam. They record whether or not they've used any antidiarrheals. We measure their hematocrit. We take their weight. We fill out this incredibly complicated form, and Jamie can attest to this. This is, I mean, as you can imagine, the more steps involved, the more likely there are errors. So when we were getting these scores back, we found that people were unable to multiply this number by 1 and get the correct answer. I mean, it's really, the more steps that are involved, the more likely there is to, the higher the likelihood of error. So in any event, this is the Crohn's disease activity index. And when we get to the total at the end, by definition, we've said if you have a total score that's less than 150, you're in remission. If you have a score that is between 220 and 450, you have moderate disease activity. If you're higher than 450, you are severe, and the highest you can score on this is 600. You actually can't get a 0 either because you can't have a 0 weight and you can't have a 0 hematocrit. But in clinical practice, that is too cumbersome. So we mostly divide patients into just whether they have mild, moderate, or severe based on their symptoms when they come to clinic. We don't ask patients to keep a diary for a week. We just say, well, how many stools a day are you having, or what's the average number of stools? And we can sort of get a sense based on their symptom, the symptom history we obtain in clinic, how severe their disease is. And this helps us determine what therapies to choose. So when it's mild disease for ulcerative colitis and we're trying to induce remission when a patient has presents to clinic with mild disease, we typically start with agents called the 5-aminosalicylic acid agents. So these are drugs like Asacol, Pentasa, Colazole. And these can be administered orally. They can take a tablet, or they are available in suppository and enema form. And typically the combination of oral and topical works better than either alone. When they have more severe symptoms, this is not enough, so we have to add some steroids, and we typically add oral steroids in the form of prednisone. Sometimes we'll add steroid enemas, and if none of those work, or if the patients are in the more severe end, the moderate range, we may start treating them with infliximab, which is Remicade is the brand name for infliximab. And when they have severe disease, they require hospitalization. They get IV steroids. They may get IV cyclosporin. They may be started on Remicade, and they typically get antibiotics because they typically present with fevers, et cetera. Well, once we are able to induce remission, we have not as many drugs that are available for maintaining that remission. So for ulcerative colitis, we can keep them on those drugs, the 5 ASA agents that we use to induce remission. We have other drugs called immunomodulators, the azathioprine and 6-MP are very good for maintaining remission, but take 3 months to kick in, so we don't use them to induce remission because it would take forever to get the ball rolling. So we use these for patients who are transitioning from steroids to one of these agents to try to get them off of the steroids. We can use Remicade or infliximab as a maintenance drug. Corticosteroids are ineffective, but that doesn't stop people from using them for years on end to try to maintain remission. And then oral cyclosporin also doesn't work. These are just some of the indications for surgery, and we use surgery to treat patients who don't respond to medical therapy. So if a patient has tried all of the treatments for ulcerative colitis that we have available now and they still don't respond, then we frequently send them to surgery. And interestingly, for ulcerative colitis, removing the colon does cure them of the colitis. So that's not the case with Crohn's disease because it typically does come back in another area of the GI tract. But for ulcerative colitis, certainly life without a colon is not the same as life with a colon, but you can have a very good quality of life without your colon. For Crohn's, we do the same thing. We classify patients as having mild, moderate, or severe disease. We also include this category of the perianal disease because if they have those fistulae that I showed you, they do much better when they receive drugs like infliximab. For maintenance of remission, we have infliximab for Crohn's, adalimumab or Humira. The other drugs that we talked about, they're also good for ulcerative colitis, the azathioprine and the 6-MP. Methotrexate is another one we use, and again, the steroids have no benefit. So you're sort of seeing a pattern as far as steroids have no benefit. So just briefly to wrap up, what about the future? This is a list of the non-anti-TNF agents. So the anti-TNF agents being Remicade or infliximab or adalimumab, which is Humira. And there now is another one, certolizumab pegol. So these are some of the agents that are currently under study. The ones that are, you can't really tell, but this one failed in clinical trial, this one failed in clinical trial. We have here Trichuris suis. This is the pigworm that's being tested in clinical trials. Probiotics are being used. Bone marrow transplant is being used. We did the clinical trial here for human mesenchymal stem cells in Crohn's disease. So there are a number of different approaches. You can see we're looking at agents that target T-cell differentiation, adhesion, T-cell activation, cytokine signaling. There are a number of different approaches to the treatment of Crohn's and ulcerative colitis that are currently under investigation. And what are the challenges? As I mentioned earlier, the patient population is extremely diverse and what I would call heterogeneous, even within ulcerative colitis. Despite the fact that all the patients have disease only in the colon, some have it only in the rectum and sigmoid colon, some have it in the entire colon, some have extraintestinal manifestations, others don't. The clinical indical indices that we currently use are very subjective. They tend to be insensitive in that they don't correlate as well with the clinical outcome, particularly endoscopy, so small changes in patient improvement would not be caught or captured by the Crohn's disease activity index, for example, and they're cumbersome to use. Measuring endoscopic outcomes is extremely costly, so frequently a study will use 10% of the patients will have endoscopy, sort of a random subset of the patients to try to contain the costs. And we don't really know what the optimal out point is and how best to define it. Is it clinical response or remission? Is it endoscopic response or remission? Is it histology showing no evidence of active disease? Is it that the patients feel better and have a normal quality of life? Or is it steroid-sparing reduction in long-term complications? These are all the challenges that face us when designing a clinical trial. So in summary, Crohn's and ulcerative colitis are chronic inflammatory conditions whose etiology is not known, but we do know there is a genetic predisposition and that patients who are genetically predisposed are also influenced by environmental triggers and immunologic factors. The hallmark of both disorders is the failure, as I mentioned earlier, to downregulate the inflammatory cascade. So this is not thought to be initially an abnormal reaction. In many cases, we believe it was an appropriate reaction to some trigger, but the inappropriate aspect is that it cannot be downregulated. So something about the patient's immune system fails to turn off once the triggering event has disappeared. The bowel tends to be the primary, or is the primary target of the inflammatory damage, but multiple organ systems can be affected. Treatment is directed at both induction but then maintenance of remission so patients don't have to keep going back on steroids. And we are working on designing and devising better instruments for assessing clinical trial outcomes. And I believe that's it. 1 o'clock. I'd be happy to take any questions.
It's really kind of interesting to me that ulcerative colitis seems to be very contained, whereas Crohn's seems to be more systemic. So can you kind of talk maybe about how you address that, although they're sort of combined together under IBD, in some ways they seem to be very different animals. And why is that Crohn's seems to really be free to go anywhere in your system, whereas colitis seems to rarely go there?
So I think I don't know the answer to your question, and it's a great question. And I guess what I would say is the two diseases are probably lumped together because they both involve the colon, and they're both inflammatory in nature, and they're both chronic. But they are very distinct in some ways. But as I said at one point, they're about, I probably didn't show you this slide, about 10% of patients with inflammatory bowel disease have what we call indeterminate. We have no idea whether they have ulcerative colitis or Crohn's because it only involves the colon, but it looks like Crohn's disease. And the challenge is to figure out which group they lean toward. So there have been a number of blood tests that are now being used with markers. And what we have found is that some of the markers track to ulcerative colitis much more dependably, and some of the markers track toward Crohn's disease. And there is a company in California, Prometheus, that has designed and has sort of a proprietary algorithm by which they will analyze all the markers that they obtain or that they measure in the blood of a patient who has inflammatory bowel disease or suspected inflammatory bowel disease. And they will tell you what the levels of each of those markers is, and what the level of each of those markers is, and then they throw all that into a computer program and say likely Crohn's disease, likely ulcerative colitis. But when you get right down to it, that doesn't really help us because you can see most of the medicines are the same for both. What we are looking for are things like, what is this Crohn's patient going to behave more like an ulcerative colitis patient, meaning that their disease will stay confined to the colon, and if we did surgery and remove the colon, could they actually do well, as opposed to the group that, as you say, it's everywhere. So if we took out the colon, it would just come back, or it would be located in another area, and they would be minus the colon and still as sick as they were before you took out their colon. So I think the diseases are lumped together historically because of common features, but the more we realize, they're not actually, they are at opposite ends, but then there's a whole gray area in between as well. And I have no idea why the Crohn's behaves the way it does, and ulcerative colitis does seem to stick to the colon. But I think a lot of that is the genetic predisposition, or the genetic makeup, if you will.
Are they presuming that they're doing studies to try to tie it to specific genetic markers?
Mm-hmm. And a lot of the twin studies are useful from that standpoint. But one of the things we were hoping to do was to collaborate with UNC and Wake Forest and start our own sort of repository, tissue and serum and down at the biorepository, because this is an area that is intensely investigated and needs to be investigated further. And we're sitting on a gold mine of patients. Every day we see dozens and dozens of patients, and between the three institutions we see thousands every year. We need to be collecting. This needs to be a much more concerted effort and pooled effort, I think, on the part of institutions that see a lot of this to try and sort it out. You're right. So if you have any money.
Hi, Dr. Onken. That's a great talk. IBD and IBS, do they have any relationship with each other?
That is a great question. The most common relationship is that people mistakenly use one label instead of the other because they both start with IB. But so interestingly, we used to think they were completely unrelated. The hallmark, irritable IBS is irritable bowel syndrome, and by definition, those people have a normal colon. So if you did a colonoscopy and you biopsied them, it would be absolutely normal. You could never find any inflammation. You could never find anything that would say this is something other. So the diagnosis of IBS, or irritable bowel, is made by excluding all other causes of symptoms. But the symptoms can frequently be the same. So the symptoms, the common presenting symptoms for irritable bowel are diarrhea, bloating, sometimes constipation, sometimes alternating diarrhea and constipation, mucus in the stool, all kinds of things that could be seen with Crohn's disease, bless you, but don't have to be. The other confounding thing is that having inflammatory bowel disease does not protect you from also having irritable bowel syndrome. So we have some patients who have Crohn's, but who also have IBS-like features, meaning that when they're under extreme stress, they start to have profound diarrhea. I mean, it's almost as though their intestinal tract is much more sensitive to changes in their outside environment. And it becomes difficult to determine whether their symptoms are due to a flare of their inflammatory bowel disease or whether it's because of stress, depression, underlying anxiety that they now have symptoms that we would call more IBS-like symptoms. So we have historically thought that those two disorders, if you will, were completely different. It now looks as though there may be some genetic markers that track to IBS in addition to IBD, whether that's a real phenomenon or, I mean, this is sort of very, very recent abstract kind of data. And interestingly, some of the antibiotics that can be used for Crohn's disease also seem to work in irritable bowel syndrome. So unfortunately, we still sort of keep those two separate, but they may be more alike than we've given them credit for. But the biggest difference is that we can find no objective evidence of any abnormality in patients who have IBS. It's purely a symptom-driven diagnosis and one that they have to meet criteria, symptom criteria, and we exclude other things like IBD. But a year from now, that story may not be true, or that answer may not hold true. Yes?
Hi, my name is Amherst. In terms of environmental, with IBS and IBD, I guess increased alcohol, does that have any type of increase, risks or anything with that?
So to date, no. We've not found any evidence that alcohol consumption in and of itself is a risk factor or protective for inflammatory bowel disease. And trust me, if I tell them that it's protective, we're going to be in trouble. So far, no. We have no evidence that alcohol plays a role in the development or sort of the presentation of IBD or IBS. But as you probably know, some people are much more sensitive to the effects of alcohol, even if they don't carry a diagnosis of IBD or IBS. And so I think what happens is that patients who have a diagnosis of IBD or IBS, who then also drink alcohol, and by drinking alcohol, it's not usually one glass of wine or one mixed drink. It's usually more than that. It may exacerbate the symptoms because in and of itself, it could cause, just excessive alcohol drinking could cause diarrhea and that kind of thing. So it's not that we think alcohol, at this point, that alcohol has a role in either triggering or precipitating inflammatory bowel disease, but it may play a role in exacerbating some of the symptoms in someone who already has it. All right, party. Thank you very much.